if you could start sharing your slides, but I will still do a little introduction and a little bit of housekeeping beforehand.
Yeah, it's all in place.
Okay, it's already sharing.
No.
Sorry,
I'm ready when you are. When you let me know.
Okay. All right, so the recording should be live. So yeah, good morning, everyone, and welcome, or good afternoon from wherever you're joining. Of course, we are a very international network, so I'm aware people might be joining from Australia. So in that case, good afternoon or good evening. My name is Sebastian Potthoff, and I'm one of the co-directors of Open Digital Health, and it's my pleasure to get these events started again. So in case you haven't subscribed to our website yet, I encourage you to do that. If you become a member on our website completely for free, we will send you all the updates about any forthcoming events as well. And we have a few planned for the rest of the year. So make sure that you do that. So I just say that before I forget it. Yes, so today it is actually my pleasure to host an event by a colleague of mine, Dr. Suresh Kumar Kamalakanan. And Suresh is an associate professor at Northumbria University and a co-director of the Cochrane Affiliate for Public Health and Disability, Cochrane India Network. And today, Suresh is going to talk to us about leading the implementation of digital health interventions in low and middle income countries. So Suresh is going to do a little talk, and while he's doing the presentation, if you could just keep yourself mute, and then we'll do some questions afterwards. But before we get started, I will also just read out a quick bio that Suresh sent me so that you have a little bit of background to his work and kind of what his role and responsibilities are. So Suresh Kumar has a versatile academic research expertise in the areas of occupational therapy, public health, disability, health systems and policy, and epidemiology. He's also a research fellow for the International Center for Evidence in Disability at the London School of Hygiene and Tropical Medicine. Since 2011, he has been a Wellcome Trust Research Fellow in Clinical and Public Health Research, developing and evaluating... Oh, got a bit of background noise. There we go. Developing and evaluating the effectiveness of technology-enabled interventions for stroke survivors in India. He is an international practitioner member of the Faculty of Public Health in the UK. He provides to the Government Disability Department of Telangana State, and he is an associate editor of the British Journal of Occupational Therapy. He contributes as a scientific committee member in the International Stroke Rehabilitation and Recovery Alliance. He is passionate about mainstreaming disability within the agenda for health, particularly in low-middle income countries, and is enthusiastic to strengthen and develop inclusive health systems for disability and social care worldwide. So yeah, it is my absolute pleasure to welcome Suresh, and at this point I'll hand it over to him.
Thank you so much, Seb. Hope you can hear me.
Yes.
Great. Okay. Thanks for the generous introduction. I thought you will kind of skim it and then talk about me in short, but you just read whatever I've sent you. So thanks, everyone. Very good morning and greetings to you all from Newcastle. And today I'll be talking to you all about an important concept in public health, which is leading digital health implementations. But the particular focus is on low and middle income countries. And I'll be talking three key concepts here. And then I'll try and finish it soon so that we can discuss and then I can answer some questions or kind of look at clarifications of certain concepts that's shared in this presentation. But thanks to Open Digital Health and Seb for this opportunity. I'm incredibly indebted to this particular opportunity. Thank you. As I said before, there are three key concepts which are complex in itself. So we have digital technology, we have health and social care, and we have implementation research or implementation science to deal with when we are looking at how do we lead digital health innovations in low and middle income countries. And of course, low and middle income countries is also a bigger concept to look at and then deal with. So in this particular presentation, I'll be talking about three key aspects. One is what is digital health in terms of looking at the perspective of the concepts related to managing and promoting health from a digital perspective or using digital technology perspectives. The second component is how is it in the context of low and middle income countries? We all are kind of very well versed with the current trends and contemporary knowledge related to digital health in high income nations, but it is also absolutely essential for us to understand the context of low and middle income countries on the topic. And lastly, I will also deal with kind of my experience of how it can be led or how it must be led from my experiences. To start off with, what is it? I'm not going to repeat or go in detail with this particular slide because we all know it and we all agree. So I've just taken stroke as one of the conditions to explain this to you in terms of the global burden of diseases that we have. So when I was born, stroke was the leading cause of death and disability. And we are still looking at stroke as the leading cause or the top 10 causes for death and disability. However, the numbers have increased tremendously. And if you can see from the slide, the numbers are more where the colors of shades of yellow, orange, red are there, and which is directly implying that the issue is definitely more in low and middle income countries compared to high income countries. And when you look at the amount of rehabilitation needs in general caused by these kinds of diseases globally, you can obviously see that there is tremendous kind of needs. And when you can compare, say, for example, Brazil, India, China, Russia, and South Africa with high income nations, or when you look at the entire kind of needs that are proven, kind of, if you provide an intervention, these needs can definitely be manageable. But these are the needs that are still existing in the world, despite the number of mortalities and morbidities, which are very medical, increasing day by day. So there is also an aspect that we forget to kind of look at when you look at the global burden of diseases, which is disability adjusted life years or disability in general. The third aspect to kind of understand before we get into my presentation is this. Whenever we talk about health systems, we assume that it has got 6 pillars and it requires governance and leadership, it requires resources, it requires provision of effective services, and it also requires money. And all of this is combinedly looked at to be kind of improving the health outcome of any population by investing in health as well as becoming responsive when there is a need. Does this happen in reality? So how is it in the context of low and middle income countries? This is a study that I've done to understand what are the rehabilitation needs of those who have survived a stroke in India in 2016. And we can obviously see the primary need of people who are surviving stroke and their caregivers is information. So when we are talking about digital technology to kind of prevent a problem or manage a problem, here is a problem which is related to what do I know about it? And this has not changed since 2016, I'm sure. And it must have been kind of rapidly increased, particularly because of the COVID-19 pandemic. And the information needs are the primary needs of people who are kind of experiencing morbidity and mortality. The second need, as you can very clearly see, is financial needs. So people either do not have money to manage their problems or they do not have information to manage their problems. And that has been a kind of situation in these contexts. When you look at why is this happening, there are two key components to understand. One is the issue of accessibility and the paucity of evidence towards improving access to health and social care in these contexts. So I have most of my research done on stroke and neurorehabilitation. And from my research, what I found out was from the service providers side, there is a barrier to invest in these kinds of problems, and the affordability of services and availability of specific services required for someone with different kinds of need following health and social conditions are not available in the context of low and middle income countries. Similarly, when you look at the consumer side, people, as I said before in my previous slide, those who experience a problem and those who care for these people are devoid of information and knowledge related to how to manage their problems. So there is a huge gap which has got issues related to affordability, availability, and needs. And if you're looking at any development of solutions which are digital in nature, looking at health or social care, then these three could be specific targets for your innovative interventions. This is something that we found out in South Africa, looking at how we can provide universal health coverage for stroke. And this is what we found out. From this particular diagram, you can see thin dotted lines and very clear straight lines which are black in color. The thin lines are the ones that are actually looked at as supporting factors that must be there in any health system or social care system in any country. However, what we found out in South Africa was some of the pillars of the health system have limiting factors, which are related to governance and regulation. In terms of resources, you can say shortage of beds and ambulances and lack of diagnostic equipments, service delivery. You have reorganization of care as a problem where we have limited initiatives to reorganize stroke care in that context. And importantly, community engagement. We have limited information of successful community engagement. So the system overall, if you look at, and this is outside the context of social determinants of health in any countries that you're looking at. So we do have systems in place, and the ideal system doesn't exist in practical situations. If you look at this particular example in India, we are talking about lots of non-communicable diseases and the expenditure for it. And as you can see, the blue line is the DALIs lost, and the green lines are the amount of investments on those particular DALIs. So there's far from realities in terms of a big gap that is there in the needs that the people have and the investment or financial allocations that people look at for meeting those needs. So all we have is kind of a fragmented health system and the social care system. This is again an example from India where we are looking at lots of population who have these needs in the bottom of the pyramid at 3 levels. And there are service provision opportunities at all these 3 levels, like we have health sub-centers, primary health centers, and community health centers. Accumulation of the people who might be helpful to provide care is there on the top of the pyramid, which is in medical colleges, district hospitals, and sub-district hospitals, right? And if you see, even in those particular top of the pyramid context, we have only 2 to 5 physiotherapists, for example, in every district. And even if you want to compensate for the availability of physiotherapists in these topmost parts of the pyramid, which has lesser population, we need about 3,200 physiotherapists per district, and we have 640 districts in India. So there is a huge shortage of people who can provide care. And for, say, for example, for a country like India, which is already towards the first leading populous country, kind of leading China, is this sufficient? Are we looking at a good health system to kind of address the needs of people who are experiencing mortality and morbidity? There comes this concept of digital health innovations. There are lots of innovations that has been kind of looked at in low and middle income countries context in the past 2 decades. So I'm going to show you some of these innovations. So this is a mobile stroke unit with a CT scan facility, first ever. So in most of the hospitals in India, if you see, the scan facilities will be either only available in tertiary hospitals and not all hospitals. And from a small hospital, if you have to reach a CT scan facility, it might take minimum 60 minutes. So by the time, if you're experiencing stroke, going to the CT scan facility and coming back, you will have a full-fledged stroke with paralysis and physical impairments. And this particular innovation, which is digital in nature, which is looked at satellite scan images of the CTs going into the hospital and for people to decide on and then take a call on when to thrombolize a patient, is now available. So this is something that's an innovation in these contexts. But that was related to diagnosis. This is related to assessment of the parameters related to general health or physiology. So you have something called Swasthya Slate. Swasthya means health. And this has been a kind of a landmark innovation in Indian context to look at assessing heart rate, body temperature, blood pressure, sugar levels, and also cardiac activity through ECGs. Through this particular small device, which are carried by the local health workers in the villages, and then the information is transmitted to the tertiary care levels. This innovation is to look at motor recovery. So we have this high-end digital robotic to assist people who have paralysis and motor problems in their upper limbs to try this out and then become kind of improve their upper extremity functions and then look at function after using these kind of innovation. It's called Be Able. And this is developed by a technologist expert from Indian Institute of Technology in India. Another device from an IITN, which is called Pluto, which has got feedback devices to help recovery after paralysis of both upper and lower limbs following any condition. And this is called Physi, where Physi uses sensors and biosensors to look at EMG activities and look at range of motion assessment and improvement after exercises when you have any problem which are limiting your range of motion of the joints as well as muscle power. We saw all those innovations, but what was missing in the innovation is this. So on one side, we have lots of innovations coming from people who are experts in clinical care. And on the other side, there is a huge number of people who have unmet need for rehabilitation and care. And the issue is we have a broken system. We have lack of availability of people. And from the personal context, there's no clue what is happening to them and how they can manage their problems. And we have a context where there are no policies for looking at this together. And hence, inaccessibility is a key issue. And within inaccessibility, something that's not looked at is the gaps in the continuum of care. So whether it's health or social care, it has to have a continuum. And without that continuum, coming up with innovations that are digital and clinical on one side, that are not kind of related to the needs of people who are experiencing health and social care problems on the other side, is not going to make sense. So how can it be or must be led in terms of addressing the issue? I started to look at this issue in 2011 when I started my PhD and then looked at developing an innovation for managing stroke-related disabilities at home in India through use of digital technology. And the innovation's name is called Care for Stroke. So to start off with, what I did in terms of looking at a digital innovation was to look at what existed and what could change. So in a context like low and middle income countries, we have hospital-based services which are expensive and available only in the private care. And these kind of hospitals are situated only in urban settings and which are predominantly driven by either a super specialized doctor and a physiotherapist. So there's no concept of multidisciplinary team to resolve issues, which are available everywhere in any place that you'll go to, like how we see in high-income countries. So I thought what could change? So hospital-based services can be changed to community-based services. Expensive care can be made less expensive, and care that is not available to everybody can be made widely available and from multidisciplinary professionals. And I amalgamated 3 strategies, which are an innovation that is digital in nature, that is purely educational, that can help self-management or supported self-management, and that is community-based. And that is how my interest transformed into an innovation called Care for Stroke. I want to show this not to say that we have lots of publications out of the innovation, but to highlight that this particular innovation has been very, very systematically developed based on the guidelines from the Medical Research Council in the UK. And we tested it for its feasibility and acceptability. It was wonderful. I gave this innovation to 30 people for 30 days, and almost every day, everybody used this innovation. And this is how I say it is feasible and acceptable in a context like low and middle income countries. And I just finished a randomized controlled trial for the past 5 years on this innovation, looking at cost and clinical effectiveness. And I must say it is green again. So it is proven effective clinically and cost-wise. However, when you look at this innovation in terms of its scalability in a context where I tested it, people came back to me, both stroke survivors and the people who provided stroke care. And then they said, this innovation talks only about managing physical problems. So we need to have lots of content related to, say, managing mental health problems, cognitive problems, and communication problems. So still, there's a huge scope for making it comprehensive. And an important aspect related to implementation is integrating this innovation in the system, which is supposed to exist, right? When I said in my previous slide, there's no system. How do I integrate this in a system where there is no system at all? So that has been a big challenge for me, which I'm still struggling to work on. And fortunately, I said this to Wellcome Trust again in last year, and I was fortunate enough to look at this particular way of making the innovation that is already existing comprehensive, and also looking at strategy identification in terms of integrating this particular innovation in the health systems in the next 5 years. And I'm very happy that this is also going to be a systematic effort, and we look towards not just developing an innovation and stopping there, saying it is clinically effective or it's feasible or it's acceptable, but moving forward and then looking at integrating this particular innovation into the health system and making sure this is value for money. Through my overall experience, when you look at the traditional route, where do I go next? So I have an innovation, I've done my work, it is feasible, acceptable, effective. And in the next 5 years, if I'm going to make sure that it is comprehensive and it is integratable, I generate an evidence for integrating a digital health innovation, right? And then I look at improving the evidence of it, and then I build capacity among people to observe this evidence and then implement this evidence. So this is a very traditional route that is kind of available. And when you look at this route, it mostly comes from people who are into academics, who are into research and academics, and who are into practice. So information of this evidence comes from researchers, educational and practitioners. However, this is the route that I found out would be something that we have to look at when you look at implementing digital health innovations in low and middle income countries. So you got to look at not just the ones or the components that I mentioned earlier, but also the components that is here, which is primarily the context in which the digital innovation and the implementation is considered, the people who are behind who can make it work, and the providers and program managers who can implement this as a program and then ensure that the program is effectively implemented in all aspects, in all the places where people have needs related to this. So the dimensions that we need to look at, rather from educational, research, and practice perspective, is health system, health policies, and health pathways perspective. And this could be a strategy to look at developing any innovation to ensure that the innovations are looked at from the perspective which are related to implementation. And when you start looking at these perspectives and these factors, obviously we are kind of leading our digital innovation to success. So what we can primarily do is brokerage the knowledge at the minute. So we have lots of evidence coming from academic researchers. We can look at ensuring we are adding one more component into implementation, which is advocacy for research, and talking about the evidence that we have, and then brokeraging this knowledge with policymakers, looking at how our research evidence can impact health systems and health policymakers from a health research perspective. Some of my experiences after understanding those concepts that I just mentioned is one innovation which is called REHABILITATION, where people use virtual technology, digital technology to take care of themselves when they have disability in general. And this component looks at both assessment technologically, treatment technologically, and communication and connection technologically. So you have evaluations, therapeutic support, as well as continuum of care, all integrated in this system, which is recently developed. And we are now looking at how best we can scale up this intervention and integrate this intervention with the existing strategies that's possible in an Indian context. There is a need for such a digital innovation in the context of Nepal. So in Nepal, this is the context we are talking about. It's definitely inaccessible geographically. However, we are looking at use of those kinds of technology that is there in one low and middle income country to the neighboring country, and then ensuring that is it possible to improve follow-up of eye care of people who need eye care, in the capital city, where it's the only place where you can access those kinds of services. So there is pragmatism in looking at care only if you look at the perspectives from how I thought of looking at it, and how I kind of described it in a few slides earlier. So definitely there are innovations happening, but it has to be put to relevance as well. And you can connect only when you understand these kinds of problems existing in neighboring countries which are having similar contexts like yours. I'm doing, or I'm working with a team of researchers and practitioners in Malaysia, looking at providing or connecting caregivers of stroke survivors and building their capacity to manage people with stroke in the community context, where people cannot reach these services and then go to a tertiary hospital to gain these services. So again, we have another example of looking at it from a health system perspective. And I must say the difference between Nepal, India, and Malaysia is, in India, you have a system which is reluctant to taking it up. In Nepal, we have a need for taking it up, and people are proactive in coming up with some kind of innovations, and they are trying to research and then see what is the need and how they can kind of come up with the innovation that is relevant to the context. In Malaysia, they've gone a step ahead, and then they are looking at how best we can work together from the government perspective and from the practitioner's perspective to identify best strategies for integrating such kind of digital innovations. And these kinds of experiences can be amalgamated together to learn about how best it is to lead digital health and social care innovations in the context of low and middle income countries. I must say I have been blessed to get all these opportunities. And now I'm going to talk to you about what are the key requirements that I thought when I started to look at leading digital health implementation in these contexts. There are only two key aspects that comes to my mind after my experiences. The first aspect is looking at a community-based scalable solution that has got considerations to all these components when we try and look at innovating digital technology, health innovations, and social care innovations. So we need to look at the perspective of patients, providers, health systems, and carers. Without all these four people considered in the development of the innovation, I don't think we can develop a comprehensive and scalable solution that can be implementable. The second key context is looking at technology itself. So we are all very good with technology. There's no doubt about it. But how do you see technology is what is very important when you look at implementation of digital health innovations and social care innovations. The concept that I already mentioned was there is a need for continuum of care. So your technology must bridge that gap. And if you want to bridge that gap, these are the key components that you got to look at. So any technology or digital innovation must look at therapeutic care continuum. If they do that, they are targeting both the community and the people who are in need. And those community will automatically be empowered, and the people who are experiencing the problem and the providers who are providing care for these kind of problems generate evidence only when the technology also connects the systems. So the technology that is going to be innovated must target the people who are having the problem, the providers of care, and also the systems. Thereby, you're creating a care continuum for people in need. You are empowering those people to become economically productive members of the society. At the same time, you are bridging the gaps in evidence to that particular problem. We tried to look at it when we had COVID-19, and we came up with a model called prepare and pre-resist. Okay, pre-resist actually means preparing, responding, and systematically transforming the services to be disability inclusive, or inclusive in terms of all kinds of parameters that you can look at. I would say digitally inclusive rather than disability inclusive. And if you can look at all these kinds of parameters in developing a digital innovation for health and social care, then you can certainly kind of address the needs that I've told among those three key people and points, where you can address the needs of people in the community with the problem. You can address the needs of people who provide care. At the same time, you can strengthen the health systems in these particular contexts. I'm just going to go through some of the slides which helped me look at how do I became someone with expertise in this area of leading digital health innovation. And the first point that comes to my mind is gaining scientific expertise. You can be a digital expert, but you also kind of look at how clinically you have to look at a problem for which you are developing innovation. And it is vice versa as well. You can be a clinician, but to develop a digital innovation, you have to understand the pros and cons, the nitty-gritties of the digital innovation that you're thinking about. Second bit is gaining expertise on the problem in the ground. That is what is very important. So it's not just we are academicians, we have got funding, and we are starting to work on the problem by calling people who are experiencing this problem to our place and then discussing with them and then saying we are co-producing digital innovations. We got to look at the field and then look at what is the reality. So can digital innovations work in these kinds of settings? Will they be able to afford a smartphone? Will they be able to actually have continuum of care, even if you're kind of looking at an educational intervention through a smartphone like the one I have, and then look at how best we have to connect people with the providers and the health systems, and what could be the best way to implement this kind of innovations that we are developing. So gaining field experience is absolutely crucial for leading digital health innovations. The other bit is I am lucky to have been working as an occupational therapist and a public health expert in disaster situations. So you are working in places where there is very minimal resources, but you have to be very, very strategic in terms of identifying how best you can address the needs of people in these resources. So you can take Ukraine, for example. People talk about war, people talk about migration, people talk about mitigation, but who talks about those who have already experiencing the health burden and the social care burden in these contexts, even before the war started? And what's happening to these people, despite the context of conflict or, say, natural disaster or man-made disasters? So I have a seat here to just explain that when I was in Nepal during the conflict for providing emergency rehabilitation, I used to kind of look at an innovation where I made seats for children suffering from cerebral palsy who were not able to sit at all, like the ones you saw in the previous slide, who were just lying on the bed with the bladder and bowel problems. And now this particular chair, which are made just from the packs of the prosthetic units that people want to be fitted with when they have amputations. So I made seats out of these boxes to ensure that this could work. So just that replacing the same concept of thinking to digital health innovations or social care innovations can work fantastically. Last but not least important aspect of leading digital innovation is advocating your research work and advocating your experiences, advocating your success stories as well as failure stories. Today, when I said this is a presentation to a small professional community of occupational therapists in India that I'm making, and if anybody is interested to participate, people question me, is it for occupational therapists? Right? So that's how people who are learning about how to become leaders in the future are thinking in a narrowed perspective. However, I would definitely say that this is an audience who have to learn from you and your experience what needs to be done when they are looking at digital health innovations from their perspectives. So building capacity among people who are interested in learning more about digital innovation and advocating your work to them is one way of looking at it. Advocating it to the policymakers, again, is another way of looking at it. So we have in an international conference of disability and health, all the leaders, including World Health Organization, the regional director of the World Health Organization, you have the minister who is related to management of or managing disability and social care. And you also have experts and policymakers in this particular conference. So there are two groups of people you should target. You can't just build capacity to those who need, and you cannot leave the people who are decision makers. So you have to look at advocacy at all levels. And here's a memorandum of understanding between the government agency and a think tank in India, saying that we will ensure we'll help you to look at social care and social protection in the state of Telangana, where I am a part of the expert committee to advise them on disability and health. The other aspect, which is very important for leading digital innovation, is collaborations and networks. The networks are important, but we don't tend to go back to them and then advocate our research and our innovation, our experiences in a way that they will take it and they will kind of like to engage with us. So that is also very important. I have been working with these agencies, and I was also very thankful to some of these agencies which had funded my work. And when I say collaboration, it should be at all levels. So in Malaysia, if you could see these three pictures, the picture at the bottom right is at the village level, where we go to the communities and then see how best we can look at health needs of the people and then look at coming up with a digital health innovation for these people. So this is at the district level or the village level. The picture at the bottom left is from the decision makers at the government and national level. And on top is the picture where we are looking at policymakers, program planners and managers and people in the field together, looking at coming up with a solution that can be best implemented and integrated within the health systems in Malaysia. So collaboration at all levels is something that's very important. Don't miss the person who is experiencing the problem and their carers also in your collaboration. They can make a huge difference to your digital innovation and the ways in which you can integrate it. There are some key achievements that's made during the past 2 decades related to my work in digital health and social care innovations. So I've got, when I first developed this Care for Stroke intervention, I got the International Student Innovation Award in the UK from the London Mayor. And when you look at the publication related to my rehabilitation needs in India, that was the most downloaded research between 2016 to 2021. So in 5 years' time, the research that's done on a particular problem in India and looking at developing a digital innovation. So this is not primarily a digital innovation, but one stone that can be for me to advance my digital innovation. And that has got a big award from the American Congress of Rehab Medicine. And fortunately, I was able to get the state award from the government on the research innovation, which is digital in nature for social care as well. So there are lots of things that you can do, make a difference, and then be recognized. However, I think digital health innovations and its implementation should look at this particular picture as success. So a person who is experiencing the problem should keep smiling internally, and not for the purpose of the picture anyway. And I think that is the best achievement that you can gain through whatever you're doing for people in need, through the combination of your expertise in digital health and social care, as well as your clinical kind of components that you've gained experience from over the years. I would like to summarize saying that it's all about bridging the gaps. It's not just about coming up with a digital innovation related to health or a condition or social care or a social condition. It's not about just looking at implementation of whatever you did just because you've developed it, or investing in something to develop just because you have money to do it. It's all about ending up with bridging the gaps that is currently existing in low and middle income countries. I think there's no big difference between high income countries as well. So bridging the gap definitely requires policies and interventions. It's not just interventions, right? And when you're trying to look at developing policies and interventions to empower people in need, I think technology could strategically drive an evidence-based continuum of care. That's something that's very important for you to look at. And in the entire process of bridging the gap, you must not forget inclusiveness. So you have to include whoever you think can create a change in your success of implementing and integrating an innovation that is digital for health and social care. Last but not least, I would like to say that building or strengthening the capacity of the existing health and rehabilitation systems for technology-driven scalable solutions, particularly in low and middle income countries, is of utmost priority and public health importance. So don't stop looking at an innovation just in a high income country setting. Try and look at translating knowledge, translating research, translating solutions and strategies to some of the solutions that's already there in high income countries to low and middle income countries context as well. And I think that would take ages for us to actually implement those kinds of existing technology and resources to a context like low and middle income countries, which is currently bearing almost all significant and major diseases with lots of people having lots of needs related to health and social care. Thank you all for this wonderful opportunity. you can contact me through these email addresses. And I'm happy to kind of now stop my presentation and answer any questions that you might have. Thank you once again.
Thank you very much, Suresh, for this really inspiring talk again. It's really nice to hear you present, and this is not the first presentation that I've been in from you, and it's interesting to see how you always bring up like new sort of nuances and aspects. So that's great. So we have some time now for some discussion, questions from the audience. So if anybody would like to ask a question, make a comment, feel free to just unmute yourself, or if you can raise your hand, so we can hand over the mic to you. Are there any questions for Suresh?
Please feel free to share your disagreements as well.
Yeah, absolutely. I think GJ just unmuted himself.
Yeah, I first want to say that I'm afraid that in Zoom, I don't know how to actually raise my virtual hand. It might not be activated, but so sorry, I'll just take the floor now and then let somebody else who can raise their hand or wants to take it. So this was very impressive. It's extremely impressive how you have this super broad spectrum, basically very theory informed, but also clearly with, as we say in the Netherlands, with your feet in the mud. So that's very impressive. Really very nice. Also very nice that you have to show the awards and then you say, but this is the real. So very impressive, excellent talk. So my question/worry kind of relates a bit to this. So you explained that it's very important to actually visit the communities and to be aware of their context, to be aware of their assets and needs before you start developing stuff from behind your desk and rolling it out into the world.
Yes.
And I completely agree. That's right. Then you kind of like moved over to like disasters and the unexpected things you can, and how you improvise there. And then I was thinking, do you think it's possible to actually help these communities in those disaster-stricken areas if you haven't actually also seen the disasters there? Is it even sufficient to visit the communities? Or do you also have to experience that kind of chaos and what it does to a community and to the environment?
That's true, JJ. Very good question. So I'll give an example where I'm talking about a child with cerebral palsy, and I go from Kathmandu, I go to a place which is, it's not peaky regions like how you look at Mount Everest. So it's definitely higher, but it's in the middle of peaks and the low-level land region. But still, there are rivers in the middle. We have floods, and when floods come, the person who is there, the child and the family who is there on top of this hill, cannot travel. So that's one. So there is geographical inaccessibility due to disaster. Even if there's no flood, it might take 2 days for them to as a minimum to travel to the district headquarters. I'm not talking about Kathmandu, which is capital. So there's inaccessibility geographically when even during or not during a disaster situation. You got to experience this, and there is conflict in addition to it. All right. So even in general circumstances, the context might be in such a way that it is inaccessible, and you got to know what is exactly making things inaccessible within the context. And what we are looking at is different kinds of context, and it's absolutely essential you understand those contexts as well. Say, for example, when there is conflict, when there is no floods, and I have to travel 2 days to take my child to this particular hospital, which is in the district headquarters, I have to be aware of, can I go? Because there might be curfew. What would happen if I go within that particular time during a curfew for 2 days? You're unsecured, actually. You're completely unsafe. What could happen to you and your family when you are out to gain those services? And the socio-demographic aspect of these people as well. Because if they don't go for work one day, the day's wage is lost. So taking that also as a context. So I think it's a mix of context that comes to picture, and it's not just the context that I've explained in the pictures. Yes.
Wow, that's even more mind-boggling. Thank you very much for the explanation.
Thank you, GJ.
Okay, we have a question here in the chat by Gemma Donovan. She says it's very interesting. Can I ask who the payers typically are in these settings? And is this a barrier to scale up and sustainability of digital health interventions?
Absolutely. So one of the biggest advantage we have, Gemma, is there are people who have smartphones, even if they are in an inaccessible context. So what they cannot access is the services, but they do have a smartphone in hand. And that becomes something very crucial to ensure that the continuum of care happens. But in general context, in most of the low and middle income countries, people pay from their pocket to access any kind of health needs. And it is not because they don't have a government system in place. They do have a government system in place, but they don't trust the system. And hence the utilization of the government health and social care systems, which are already fragmented and ineffective, is not tapped for its strength that is there. So even if a government comes up with an application and then says, we have it, use it, I don't think people will be happy to use that, compared to, say, for example, Open Digital Health comes up with an innovation and then says, please take it. Hope I answered your question, Gemma.
I think you did. Great. Yeah, so that's an interesting one, actually, and I was wondering about that as well, in terms of the government strategies, and maybe from your perspective, because from other presentations that I've seen you do, you talk about doing this kind of knowledge brokeraging and on the government level, and you're part of committees. Can you maybe share some of your experiences there? Because it sounds like it's a very, and from previous talks that we've had in Open Digital Health as well, in countries like India, you have this like beautiful kind of bottom-up approach where you have all of these people who have such expertise and who drive all these innovations. But how is that communication with those people from the ground up, from the bottom up, and the government, and your experiences?
Thanks for asking me that question, Seb. So I must definitely say, all the people in this particular call can be people who are already converted or thinking that it is all possible. However, one big group of people who we have to convert are these policymakers and program planners and managers. You go there, you sit with them, they don't really understand what is the innovation or how to appreciate evidence. So for them, research is something that is helpful only if you translate your interpretations in a plain language. And I think the people who are innovating solutions should kind of gain skills to talk in their language and then say very plainly, this is the need, this is what we found out, and this is how we think so it would work. So it's basically trying to groom yourself with a different kind of skill to advocate. So because you are, say, for example, a PhD research scholar, because you are somebody who has got a big funding from Wellcome Trust, for example, the people who are sitting in that particular table is not going to understand who you are. And for them to understand who you are, you have to speak a very plain language. At the same time, you also have to appreciate what exists in the system. And this has become my strategy over the period of years. So to work with the system, or to work for the system, you have to work with the system. So talking to them about what you don't have is not going to help. So talking to them about what they have and how best they can utilize what they have for helping us could be a win-win situation.
Yeah, I think the same applies in any system really, but probably it's even more so applies in India. The fact that you need to be able to speak in different languages and to address the different stakeholders. That's a really good point. Do we have any other questions from the audience? Any comments?
Hi, I have a quick comment here. I think this was a brilliant presentation. One of the things which I am very interested personally is also in exploring multiple stakeholders and how sort of, as you mentioned, including the system itself, maybe looking at a few government sites, having a research partner, maybe going to, a few organizations which support evidence-based grants, right? I mean, how does having multiple stakeholders right from the start help you in planning for long-term scale-up?
I think that's a brilliant question, Sanya. Yeah, if you're not completed the question, I'll just wait.
No, I'm saying that no, basically, what I have experienced, while working in the digital health AI spaces, I mean, what I've learned is sometimes when we are planning new interventions, new models, even while in the planning and conceptualization stage, it's always good to sort of, like step back and see if I have to look at a midterm scale up plan. Would this be acceptable by the government? Or what is the sustainability approach that we are looking at? I also wanted to get your inputs and your learnings here. Sometimes what happens is, when we start looking at building these innovations, we are so passionate. We go to the ground, we look at how the different sort of product capabilities will look like. Sometimes we fail to see the macros and look at how we can leverage the ecosystem to also plan for scale up and sustainability. So wanted to hear from you your inputs.
Thanks, Sanya. It's a very important question as well. And your experience, I'm not going to disagree with your experience at all. But something that is very key here is there are different kinds of stakeholders in terms of implementation. One is the private stakeholder, who kind of occupies the majority of the domain for scalability and implementation. And because there is a profit there. So whatever digital health and innovations that we have in this particular context primarily comes from private people. There are also people within the government system looking at scaling up some of the innovations, which is perfect. But what to look at in both these contexts is taking into consideration the civil societies and the charities perspective, who are kind of trying to bridge the gap in reality, but either they don't have funds to do it, which the private occupier will have, and they don't have the data and connections in the community and the systems that are there possibly which could help. The primary issue here to consider is whether it's private or government or civil societies, they can get together, understand, innovate a digital health solution, but they cannot look at its sustainability unless and until they start to conceptualize the key performance indicators to monitor how well it can be implemented right at the beginning, right? That's what is very important. We all develop innovations. We all look at strategies for scaling up, but what we miss out is, okay, next 3 years, how do I actually say that the innovation is implemented effectively in the community? In an Indian context, for example, we have this national program for, in 2006, it was called National Program for Prevention and Control of Cardiovascular Diseases, Cancer, Diabetes, and Stroke. So we have 4 conditions, of which 2 are risk factors. And this program is currently, last month, was renamed as National Program for Non-Communicable Diseases, including 3 other conditions like fatty liver or alcoholism and depression, right? However, if you look at from 2006 till date, has there been any one single report of the implementation of this project in any one particular state? You might be surprised that there isn't any. So what we have to look at, in addition to whatever we are doing for scaling up or implementing, is also to look at monitoring whether the intended consequences are achieved as proposed or as planned when we started to conceptualize those innovations. I hope that helps, Sonia.
Thank you very much, Sanya, for the question. And yeah, to finish off it timely, thank you again, Suresh, for this really interesting talk. It's a pleasure to have you present here on this platform. I would like to ask you before you sign off or after you've signed off to just complete our quick evaluation survey, which I've posted in the chat now. So if you could leave us your feedback, kind of talks that you would like to see in the future, and any other impressions on how we can improve these events for you, that would be very much appreciated. Thanks again, Suresh, and everyone for attending this event, and enjoy the rest of your day.
Thank you, Seb. Thank you all.
Thank you. Bye.
Thank you. Bye, everyone.
Seb, thank you for the opportunity.
No worries. Thank you very much for the talk. It was I love that you change it up all the time, and you look at different dimensions and always bring in new angles. So that's really nice. So I'm not getting bored either. It's perfect. Not that I would get bored in any case, but yeah, no, it's really nice to see how you always tailor your talks depending on the audience. So that's really nice. A lot of things to learn from you.
Oh, my pleasure.
Yeah,
Thanks,
so that
Seb.
was really nice. I hope I wish you all the best also with your conference. Are you traveling somewhere
No,
to
the
do that,
conference
or?
this is at the uni itself. So this is, but people are coming from elsewhere.
Okay, so you have international visitors.
That's right.
Oh, that's exciting and nerve-wracking at the same time.
Absolutely.
You'll have to, well, hopefully the weather holds up for them, and they get to enjoy the best of Newcastle. Maybe you take them to the coast as well.
Yes, I will do it.
Okay.
So we'll connect later because I've got a class
Sounds
now.
good. Yeah, let's catch up soon.
Thank
Bye
you very
bye.
much. Bye.